Good day everyone. Now we will tackle about integration of evidence-based practice in the care of clients with psychological problems in relate to oxygenation, fluid and electrolytes, infection, immunologic response, and cellular aberrations. Evidence-based practice is an approach to healthcare that integrates the best available research evidence, the clinical expertise of healthcare professionals, and the unique values and preferences of patients. By combining these three core components, EBP ensures that care decisions are safe, effective, and tailored to each patient's needs. This approach also supports informed decision-making when healthcare teams consider changing or updating clinical protocols, making sure that new practices are grounded in strong evidence and aligned with the patient-centered care principles. The three pillars of evidence-based integration. First is best research evidence. This uses up-to-date, high-quality studies, clinical guidelines, and systemic reviews to support clinical decisions. This ensures that the selected interventions are scientifically validated, effective, and safe for patient use. Next is clinical expertise and practical experience. This draws on the healthcare team's skills, judgment, and past experiences in managing similar cases. Clinical expertise helps interpret research findings and apply them appropriately in real-world situations, especially when patient conditions are complex. Lastly, we have patient values, preferences, and ethics. These takes into account the patient's beliefs, cultural background, personal priorities, and informed choices. This component ensures that care is respectful, ethical, and tailored to what matters most to the patient, promoting shared decision-making. Evidence-based intervention for clients with oxygenation problems focus on improving ventilation, enhancing gas exchange, and preventing respiratory complications. These interventions are supported by research and clinical guidelines to ensure safe and effective respiratory care. First, we have incentive spirometry. It encourages deep breathing and lung expansion, helping prevent atelectasis and improve ventilation, especially in post-operative or immobile patients. For example, a post-abdominal surgery patient uses the incentive spirometry every hour, reducing the risk of collapsed lung segments. Next is early mobilization. This promotes better lung ventilation, enhances secretion clearance, and decreases the likelihood of hospital-acquired pneumonia. So for example, a patient recovering from pneumonia is assisted to sit and walk early, resulting in improved breathing and quicker recovery. Next is high-flow nasal cannula. This delivers warm, humidified oxygen at high flow rates, improving oxygenation and lowering the work of breathing in patients with hypoxemia. For example, a patient with acute respiratory distress is placed on HFNC or high-flow nasal cannula, showing improved oxygen saturation without needing intubation. Next is positioning strategies. Positions such as semi-Fowlers enhance lung expansion, while prone positioning improves oxygenation in patients with ARDS by promoting better ventilation, perfusion matching. For example, a patient in semi-Fowler's position breathes more comfortably, while an ARDS patient placed in prone position shows improved oxygen levels. Next, we have smoking cessation counseling. It helps reduce airway inflammation, improves oxygenation, and enhances long-term respiratory function using evidence-based counseling techniques. For example, a COPD patient receives counseling and nicotine replacement therapy, leading to a reduced dyspnea and improved oxygen saturation over time. EBP in oxygenation ensures each intervention is backed up by strong research, allowing clinicians to optimize gas exchange, prevent complications like pneumonia or respiratory failure, and provide safe, effective respiratory care. Evidence-based care in fluid, electrolyte, and acid base. These prevent cardiac arrhythmias, shock, edema, and organs dysfunction. First, we have strict intake and output monitoring. This helps detect early signs of dehydration, fluid overload, or electrolyte imbalance by accurately tracking fluid intake and losses. For example, a patient with heart failure is closely monitored with daily I&O, allowing the nurse to identify developing fluid retention early. Next, we have evidence-based IV replacement protocols. These standardized guidelines, such as safe potassium infusion rates, ensure electrolytes are corrected safely without causing complications. For example, a patient with hypokalemia receives potassium at the recommended rate, preventing arrhythmias while restoring normal levels. Next, we have early identification of acid-base imbalances. These, using ABG interpretation, standards enables timely recognition of metabolic acidosis or alkalosis and guides appropriate treatment. For example, ABG results in a diabetic patient show metabolic acidosis, promoting rapid initiation of insulin and fluid therapy. Next, we have evidence-based sepsis fluid resuscitation. Administering the recommended 30 ml crystalloid bolus improves perfusion and reduces the risk of septic shock and organ failure. For example, A septic patient receives the evidence-based fluid bolus immediately in the ER, stabilizing blood pressure and improving lactate levels. Evidence-based care in infection and inflammation. These interventions focus on preventing infection, detecting deterioration early, and ensuring timely appropriate treatment to reduce complications. First, we have antibiotic stewardship. It ensures antibiotics are used only when necessary, at the correct dose and duration, to prevent antibiotic resistance. For example, a patient with a viral infection is not given antibiotics following stewardship guidelines. Next, we have sepsis bundles, surviving sepsis campaign. Standardized time-sensitive steps such as early lactate measurement, antibiotics, and fluid resuscitation improve survival in septic patients. For example, a patient meeting sepsis criteria receives antibiotics within the first hour, resulting in faster stabilization. Next, we have wound infection protocols. Evidence-based practices like chlorhexidine, cleansing, and sterile dressing changes reduce the risk of wound contamination and infection. For example, a surgical wound is cleaned with chlorhexidine per protocol, preventing post-operative infection. Next, we have early detection tools such as MEWS or MEWS or QSOFA. These are scoring systems help clinicians identify early signs of deterioration, allowing timely intervention before severe infection or sepsis develops. Example, a rising MEWS or MEWS score alerts staff to a patient worsening condition, promoting early physician evaluation. These evidence-based interventions reduce mortality, lower antibiotic resistance, and ensure timely recognition and treatment of infection and inflammation. First, we have neutropenic precautions. These reduce exposure to harmful pathogens through safe food handling, avoiding fresh flowers, and strict hygiene. For example, a chemotherapy patient avoids raw fruits and vegetables and follows hand hygiene protocols to lower infection risk. Next, we have central line infection prevention bundles. These use sterile techniques for insertion and maintenance to prevent bloodstream infections in immunocompromised patients. For example, a nurse performs chlorhexidine skin prep and daily dressing checks for a patient with a central line. Next, we have vaccination protocols. These ensures appropriate immunization are given based on evidence to protect against preventable infections. For example, a patient with HIV receives the influenza vaccine as recommended to reduce risk of severe illness. Next, we have monitoring for opportunistic infections. This regular assessment helps detect infections that immunocompromised patients are susceptible to. For example, a transplant patient is monitored for fever and unusual symptoms, resulting in early detection of a fungal infection. We have protocol adoption. When adopting a new practice or updating a protocol for immunocompromised patients, clinicians considered best research evidence, the experience and judgment of the healthcare team, the ethical, cultural, and personal preferences of the patients. This ensures that changes are safe, practical, and aligned with patient-centered care. First, we have evidence-based pain management. Standardized protocols like opioid therapy for sickle cell crisis ensure safe, effective, and relief while preventing undertreatment. For example, a patient in sickle cell crisis receives IV opioids following evidence-based dosing guidelines, resulting in rapid pain control. Next, we have chemotherapy safety standards. These guidelines for preparation, administration, and monitoring reduce medical errors and toxicity risk. Example, a nurse uses PPE and follows double-check protocols before administering chemotherapy to ensure patient and staff safety. Next, we have targeted therapy and immunotherapy. Treatments guided by tumor markers or genetic testing allow for more precise therapy with fewer side effects. For example, a patient with HER2 positive breast cancer received trastuzumab, a targeted therapy proven to improve survival. Next, we have screening guidelines. Regular evidence-based cancer screenings enable earlier detection and better treatment outcomes. For example, a woman received routine mammography, leading to early detection of a small treatable tumor. Steps in evidence-based practice process. First is ask clinical question in a PICO format. Formulate a clear, focused question using patient or population, intervention, comparison, outcome to guide search for evidence. Next is search for high-quality evidence. Locate the most reliable and current research through databases, clinical guidelines, and systemic reviews. Next, we have evaluate the validity, reliability, and applicability of the evidence before using it in clinical decisions. Next, we have integrate with expertise and patient factors, combine evidence with the clinical judgment of the healthcare team and the patient values, preferences, and unique circumstances. Next, we have implement the intervention. Apply the evidence-based strategy in practice while following protocols and monitoring safety. Lastly, we have evaluate outcomes. These monitor patients' responses and outcomes to determine the effectiveness of the intervention and inform future care. Integrating evidence-based practice across areas like oxygenation, fluid and electrolyte imbalance, infection, immunologic response, and cellular aberrations highlights the importance of combining current research, clinical expertise, and patient values. Applying EBP ensures safe, effective, and patient-centered care, improves outcomes, prevents complications, and support continuous improvement in clinical practice. And that would be all for my report, and thank you.